Yes, I can.
Was it? Did you save it? I closed, but it will ask me to save it or not in case it's not saved. Okay, L5. Okay. All right. So the next topic is management of thoracolumbar trauma, and that's going to be non-surgical management of thoracolumbar trauma. So just a short introduction, still major killing factor despite the modern advances, and also main causative for morbidity. We had a good epidemiology review by Mehmet, but I will just mention something that's related to my talk later on. So about 15 to 20% of the fractures of the thoracolumbar region are not complicated with neurological symptoms. And up to 80% of these fractures can be treated conservatively, according to research. So all the variety of the fractures in the thoracolumbar region, they can be from simple non-displaced fractures to complex fractures. And we have to determine which one is stable, which one is unstable, so we can determine how to treat that, of course. We will hear later on that more. So it's just an example that probably if I ask you to vote unequivocally, we all will vote that we have to operate that as surgeons, and maybe also that. And the majority of us probably will try to treat conservatively this, but there is not black and white cases always. So we have to use classifications. This is one of the, as we heard, this is one of the most widely accepted and used classification, the Yale classification. So if we have to vote on C type or B type, we will probably all of us vote for surgical treatment. This is almost intuitive decision, but that's not the case for the type A fractures. So type A and type A0 and type A1 fractures, yeah, they unequivocally probably we will vote to treat this conservatively. However, that's not the case for the A2, A3, and A4. So type A2, 3, and 4, A2, 3, and 4 can be treated conservatively if no significant vertebral body collapse, kyphotic angulation, or canal compromise with neurological treatment, neurological impairment, sorry. So this is how we treat non-surgically thoracolumbar trauma with analgesia, bed rest, and bracing. Do we have level 1 evidence, and do we have good papers with regards of non-surgical treatment? I have found one good level 1 paper. This is a randomized control trial from Canada, from 3 centers. They have evaluated patients which were treated conservatively with thoracolumbar burst fracture without neurology. Some of these patients were treated with TLSO, and some were treated without. And so the authors found that at the primary endpoint of 3 months post-injury, there was no difference in Roland Morris Disability Questionnaire, Visual Analog Scale SF36. There was no difference in patient satisfaction. There is no more kyphosis in non-brace group, and there is no difference of length of stay. I found also one good paper, which is classified as level 2. Another randomized controlled trial pilot study, 2 centers to compare again same non-operative treatment of thoracolumbar burst fractures with and without bracing. The authors found that there is no difference in follow-up with visual analog scale, ODI, SF36. There is no difference in fracture on the vertebral body height loss and sagittal cup angle between the 2 cohorts. And these authors, however, they found significant shorter length of stay with the patients which were treated without brace, which was interesting for me. There is another paper which is just level 4 that suggests the same, no difference in the functional outcome and no difference in the quality of life tests. So I found this paper, which is another recommendation coming with the endorsement of CNS and ANS. The strength of the recommendation is grade B, based on 1137 abstracts reviewed. So the authors recommend that decision to use brace is at the discretion of the treating physician. It will make no difference, but it will make no harm. And that's why you can use it, if you like. So the statements that I have created, aortic type B and C fractures should not be treated conservatively. Shall we vote on that?
So if you have these guidelines and somebody treats because of a particular reason, you know, there may be some other problem, polytrauma or whatever. So you can't have a bold statement like that, that should not be treated. So maybe you could say, if possible, something like that. Yeah, or yeah, that's the right word. Preferably should be treated, should not be treated. Because, you know, if somebody's polytrauma, you don't have environment, the theater is not there, whatever, and somebody, then you have these guidelines and the guys would be sued.
I would rather not use capital letters like not, such things. Also in the second sentence, I see.
Okay, so let's vote on 1.
Okay. Number 2, aortic type 2, A2, 3, and 4 can be treated conservatively if no significant vertebral body collapse, significant kyphotic ambulation, or canal compromise with neurological impairment.
If there is no.
Yeah. Well, we will define that probably in the later course. So this is something that I start.
Actually, you have the data on
it. Okay, well, shall we define it then? Now.
I have it.
Okay. So shall we vote on this? Okay. All right. Okay, number 3, bracing for conservative treatment of TL fractures is not changing the outcomes.
That has no scientific.
Or we can say there is no evidence that the bracing has a positive effect or whatever.
There's no strong. Yeah.
There is actually no
evidence at all.
There is no clinical evidence that bracing or
grade 1. We don't have many grade 1.
Yeah. There is no clinical evidence that bracing or conservative treatment of thoracic fracture will improve the outcome.
Good.
Okay.
It has to be capital, please. The patient we are voting.
Okay. And then the last one is bracing for conservative treatment of thoracolumbar fractures is not associated with adverse effects and can be used on discretion of the treating physician.
Do you want to vote on this?
That was the recommendation from the ANS, CNS, and that's what they concluded.
Yeah, but this is a very political and unnecessary sentence. I have read also that AANS recommendations in the discretion of treating physician. What does it mean? It depends on you.
Yes.
So why do we write recommendations?